broadcast is now starting. All attendees are in listen-only mode.
Checking in again. Are we ready to start the presentation?
I am. You want me to just go ahead, or are you introducing?
No, it's fine. I actually thought I'll get a go ahead from the organizers, but I'll start by introducing you. It's a great honor for me to introduce Dr. Wiggins tonight for our webinar. He's the Professor of Radiology and Imaging Sciences at the University of Utah in Salt Lake City, as well as an adjunct professor in the departments of otolaryngology and head and neck surgery and biomedical informatics. He is currently the program and chair of the Society of Imaging Informatics in Medicine, and has reviewed scientific papers, several chapters in books, and has presented at more than 500 national and international lectures on neuroradiology, informatics, and teaching and education, for which he's received several awards. It's really a great honor for us to welcome you tonight to give us this lecture on post-operative temporal bone. And we're looking forward to hearing your thoughts on this matter. Thank you very much.
Thank you. Thank you. Hello, everyone. So today we're going to talk about post-operative temporal bone, a very complicated area, just like post-operative neck and cervical soft tissues. I have nothing significant to disclose. I don't own temporal bones or operations. And so we're going to look at the anatomy that we think about and talk about the different approaches in post-operative temporal bone cases, review a little bit about how we image these cases, and try to think about it a different way so that we can identify and think about it analytically and go through the process to evaluate these complicated cases. Just like post-operative neck cases, these post-operative temporal bones can be very complicated. So I'm going to try to break it down and talk about how I think about this. So for each case, I think about the approach. How did they get there? The plasties, if they did anything with the reconstructing the ossicles themselves, and kind of the ectomies, or what did they cut out while they were there? So we're going to start off with the approach. How did they get there in the first place? So we have a lot of different approaches that we talk about with these cases. We have transcanal if we're going through the EAC itself, post-auricular through the facial recess, retrosigmoid, translabyrinthine, and the middle cranial fossa approach. And sometimes, like a lot of things, depending on your patient population, you may see more or less of some of these. The neurosurgeons are going to be more comfortable doing a posterior fossa retrosigmoid approach or middle cranial fossa, whereas if you work with neuroontologists, you may see a lot of translabyrinthine approaches to the temporal bone itself. And when they think about the temporal bone itself, they're going to spend a lot of time drilling very subtly with their little diamond burr drill through these mastoid air cells. Sometimes they're just taking out some of the lateral mastoid air cells, but sometimes they're going deeper and trying to get down to the middle ear structures in those areas. So when they think about where exactly the facial nerve tympanic segment is, where the cochlear promontory is and all these structures and how they get to the ossicles through a transmastoid approach, it's very different than how we think about it on cross-sectional imaging. And they can actually go all the way through and reach the internal auditory canal from this approach itself. So first, I think about the approach. How did they get there? So we have a transcanal approach. Are they just going through the external auditory canal to get to the tympanic membrane itself? We have a middle cranial fossa approach. For the neurosurgeons, usually they're going through the middle cranial fossa above the temporal bone and then going down. We have a translabyrinthine approach. And this approach, you're going posterior to the external auditory canal, and you're usually going through the vestibule and the semicircular canals to reach the mastoid air cells themselves. There's a pre-sigmoid approach going in front of the sigmoid sinus itself. And then we have a retrosigmoid approach when you're approaching everything from the posterior fossa, and we're going immediately medial to the sigmoid sinus. And then there's the posterior fossa approach that's more common with the neurosurgeons, especially to approach the cerebellopontine angle and the internal auditory canal if you have a neurosurgeon trying to reach those areas. So those are our approaches and how we get through those areas just in a graphical form. When we think about that actually on imaging, we can look at actual cases and think about how they got there in that particular case. So here's an axial T2 sequence. So we see a lesion within the internal auditory canal and the cerebellopontine angle, and we see how some of the cranial nerves are draped over this lesion, and it's avidly enhancing. So a lesion here in the CP angle 80 or 90% of the time, that's going to be a vestibular schwannoma. But the approach from a neuro-otologist may be very different than the approach from a neurosurgeon. If a lesion is going way laterally into the interlaudatory canal so that there is not a significant CSF cap, I don't see any CSF lateral to our lesion, then the neuro-otologist will do a translabyrinthine approach in this case. They'll go through the vestibule and the semicircular canals to approach that area. So this is that patient postoperatively, and you can see this translabyrinthine approach to reach the interlaudatory canal. So they did surgery right through the vestibule and the semicircular canals. They cut off the back wall of the interlaudatory canal to resect that lesion from this approach at that area. So that is a translabyrinthine approach. So the labyrinthine part of the temporal bone, we have the cochlea, the vestibule, and the semicircular canals. So this is a translabyrinthine approach that we're going through the vestibule and the semicircular canals. Now, if we have a lesion, a patient that we think has dehiscence of the roof of the semicircular canals, we're going to think about a middle cranial fossa approach to try to cover that area or just to obliterate the superior semicircular canal. This is a patient who had bilateral superior semicircular canal dehiscences. So in this case, we had a middle cranial fossa approach. So they did a craniotomy of the middle cranial fossa, and we can see how they've laid down cement over that superior semicircular canal. And in this case, sometimes they try to obliterate the superior semicircular canal. They may actually inject material like cement, hydroxyapatite or something else, into the superior semicircular canal. So here's kind of the duck head that we see in the coronal view. So the head of the duck is the vestibule, the beak is the lateral semicircular canal, and the neck is down to the basal turn of the cochlea. And in this case, you know, the cement that is laid down over the superior semicircular canal dehiscence in this case through a middle cranial fossa approach to the temporal bone. So we can also use MRI to try to identify and distinguish these cases. So here is a post-contrasted MR where you see on this axial post-contrasted the enhancement not only within the interlaudatory canal and the CP angle, but it's extending into the basal turn of the cochlea. And we see here on the T2 sequence how we've lost the bright CSF-like sequence within the cochlea, but also within the vestibule and the semicircular canals. So we can think about this as a transmacular schwannoma. It's crossing the lateral aspect of the IC and is going into both the cochlea and the vestibule at that level. So that's a transmacular schwannoma. So a neuro-ontologist may approach this with a translabyrinthine or transmastoid approach. Here we see in this case postoperatively where we've resected all of the mastoid air cells, and we see here normally the interlaudatory canal, the cochlea, and the vestibule on the left, and on the right those have all been surgically resected trying to approach this lesion. So it's kind of a transmastoid approach. They just went right through all of those mastoid air cells. Here's another case preoperatively. Now this case is kind of in the posterior CP angle with a mass that's dural base, avidly enhancing on the post-contrasted, a good appearance for a meningioma at that location. So this patient, you can imagine, would be good to approach from the posterior fossa. So here's the postoperative imaging, and this is a posterior fossa approach or a craniectomy of the posterior fossa, and we see some fat packing in the surgical bed to resect this. So we can resect a portion of the posterior wall of the interlaudatory canal to approach a lesion within the interlaudatory canal itself from a posterior fossa approach, but this lesion was just to approach the CP angle lesion at that area. So that is a posterior fossa approach more commonly used by the neurosurgeons. The problem with this approach, especially if you have a lesion within the lateral aspect of the interlaudatory canal, is that the surgeons are putting a lot of pressure, torquing and retracting the cerebellar hemispheres. And because we have the transverse sinus to sigmoid to jug going right through this area, this approach will put a lot of pressure on the cerebellar hemispheres. And we may end up with a postoperative venous ischemia if we injure the transverse or sigmoid sinus at that level. And this patient unfortunately had a venous ischemia in that case itself at this level. So it's kind of a complicated approach, but we want to be very careful if they do that approach that we're evaluating the posterior fossa in that way and being sure we don't cause a venous ischemia in that case. So those are the approaches. We think about how did they actually get to the portion of the temporal bone that they're interested in. So next we think about the plasties. There are a lot of reconstructions that we might do around the tympanic membrane and the ossicles themselves when they get there. So one of the first plasties we think about is the canaloplasty if they're trying to reconstruct part of the canal itself. A maringoplasty if they're reconstructing the tympanic membrane. We have tympanoplasties and then ossiculoplasties if we're reconstructing the ossicles at that level. So here's a case that was a tympanoplasty. It's not something we usually think about evaluating by imaging on cross-sectional imaging, but here on the CT, we just see some thickening of the tympanic membrane itself. That could be a lot of different differentials or a lot of things we might consider in this case, but this patient had a transcanal approach and a partial reconstruction of the defect of the tympanic membrane itself. So this thickening may be all that we see with a tympanoplasty, that kind of approach to the tympanic membrane itself. Now, if we reconstruct the ossicles, we often talk about a PORP or a TORP. So a PORP, a partial ossicular replacement prosthesis, or a TORP, a total ossicular replacement prosthesis, is when we're using usually some man-made material to reconstruct the ossicles themselves. But we also have a Stapes prosthesis and an Incus interposition graft that we may use to try to reconstruct some of those ossicles. So we'll look at examples of each of these. So first we have a Stapes prosthesis. So we have an allograft material that's usually we think about kind of like a shepherd's hook with a long process that connects the Incus to the oval window itself in the Stapes footplate. So here in this graphic, we can get an idea kind of that Stapes prosthesis in place. So if we look at that graphic, we see here the normal tympanic membrane. So the TM goes from the scutum up high to the tympanic annulus down low. So the malleus has the little undwelling or umbo that connects the manubrium of the malleus to the head of the malleus, and then the long process of the Incus that connects to the Stapes. Here's we have resected the anterior and posterior crura of the Stapes, and we still see the Stapes footplate in place at the oval window, but we have a Stapes prosthesis that is replacing the Stapes crura. So here's that shepherd hook Stapes prosthesis in place that is connecting the long process of the Incus over to the oval window and the Stapes footplate itself. So that's a graphic showing this. On cross-sectional imaging, depending on how much of the prosthesis is metal versus plastic, we see a very different appearance. Here's a patient at a Stapes prosthesis, so we just see a large metal linear area going over towards that oval window on this axial CT. So on the coronal CT, we see the same thing. So we do see the malleus and the Incus. Here we see the long process of the Incus going down. It's articulating with that linear metal strand. That is the Stapes prosthesis that's going up towards the oval window itself. So sometimes these are very metal and sometimes these are plastic and are hard to evaluate. So this is a case where you have bilateral coronal CT images, and we're at the level of the duck head. So the head of the duck is a vestibule, the beak is a lateral semicircular canal, and the neck is going down to the basal turn of the cochlea. So we should be at the oval window, and we see abnormal bone that is a little bit less dense than the normal oticapsule. The oticapsule, the normal bone that is around the vestibule and the cochlea, should be very dense, should be dense as bone in the body. That's why we want to use a much wider window when we evaluate the temporal bone, something like 4,400 for window level setting. But here we see spongiotic bone that's being laid down in the oval window niche. And here we see a Stapes prosthesis that's going through that spongy bone to get to the oval window itself. When we look on the contralateral side, though, we see the prosthesis is down here. It's not going up towards the oval window. And when we compare the axials, on this side, we see the abnormal spongiotic bone consistent with otospongiosis or otosclerosis, but we still have the Stapes prosthesis going up to the oval window. But on the contralateral side, we see that the prosthesis is laying down in the back of the middle ear cavity. So this prosthesis on this side was actually pushed out of the oval window niche by the buildup of this spongiotic bone from this patient with otospongiosis or otosclerosis in that area. So this Stapes prosthesis on the right is in the correct location, but on this patient on the left, that prosthesis was pushed out of the oval window niche by the buildup of this abnormal spongiotic bone that we see with otosclerosis or otospongiosis. Now, I was looking at these cases years ago, and I was talking to my neuro-ontologist because it looked like a lot of the prostheses seemed to extend way through the oval window niche and through the oval window into the vestibule itself. So I was trying to talk to them about the different models that we had that were steel or fluoroplastic that showed up very differently on our imaging, and trying to differentiate all the different models because they're constantly coming up with new makes and models of these prostheses. So it's very difficult actually to keep track of which make and model we should see how well and how far it should extend through the oval window niche and through the oval window itself into the vestibule. So we decided to kind of do a test to try to image these cases and see. So first we took different Stapes prostheses. So on the top here, we see the fluoroplastic model. So this portion of the shepherd's hook of the Stapes prosthesis is plastic. And on this lower model, we see this is stainless steel on that model. So just an example, if you've never seen these prostheses up close, how they look on their imaging. So I took these two prostheses and I tried to do a CT on them. So this is what I saw in the CT. So I actually took the two prostheses and I very carefully laid them on a small pile of Kerlix sponges. And this is the fluoroplastic prosthesis on a zoomed in image, just looking at on packs, just like we would a temporal bone CT. And this is that stainless steel model for the Stapes prosthesis. And when we zoom in on those models, we get an idea of kind of being able to think about, or at least measure how long those are and think about where the hook is. You see the hook much better with the stainless steel model, but it's very dense with this portion that goes up towards the oval window niche. So we took these prostheses and we took cadaveric temporal bones and we did kind of the routine approach. So this is the view that the neuro-ontologist sees on a translabyrinthine mastoidectomy when they're going through, and they see here the long process of the incus, and here the hook is in place, and we see here this is the plastic version of the Stapes prosthesis going up towards the oval window itself. So we put this prosthesis in place through a transmastoid approach, and then we kind of flipped around the patient and did a CT on it. So here's a CT of the fluoroplastic cadaveric temporal bone, and here's a CT of the steel model. So we can see both of these look like they're going through the oval window into the vestibule itself. So we were trying to figure out what is normal on imaging, what should we actually see with these models. So then we took those cadaveric heads and we went in the other direction. So we tried to approach it intracranially. So here we've gone from the cranial vault. Here we see the internal auditory canal with those cranial nerves going in the IC. So 7 and 8 in the superior and the inferior vestibular nerves. And we dissected away the bone and we see the cochlear promontory with that little prosthesis in place. And we tried to measure exactly how much, if we cut into the vestibule on the other side, how much of the prosthesis do we actually see sticking out into the vestibule? And then we compared that measurement. So we tried to actually measure it with calipers to see how much was sticking out. And we compared that measurement with how much was actually sticking in on the CT examination to compare. So we showed in this way that some of these Stapes prostheses do stick out quite a ways into the vestibule through the oval window niche, but some of them are actually made to do that, so that's okay. It's more important as to whether or not the Stapes prosthesis is working when we evaluate those studies. So it may be normal to see some of these extend into the vestibule through the oval window itself. That's okay. It's more important whether or not it's working or not. So those are the Stapes prosthesis in those cases. So next we have the Incus interposition graft. So here we actually take the Incus out of alignment with the malleus, the Incus, and the Stapes, rotate it around and reshape the incudal head to connect the malleus with the Stapes itself. So if somebody has had trauma and we think that the Incus is not a normal position, we might try to reconstruct it in this way with an Incus interposition graft. So here in this graphic, we see the malleus going up. We've disarticulated the Incus and kind of turned it around so that we're articulating the Incus head with the Stapes superstructure, and we're connecting the long process of the Incus to the long process of the malleus. So we have disarticulated the Incus and then replaced it back in position. So again, if you don't have neuroodontologists who are not doing this kind of procedure, you may not see this very often, obviously. But here's an example of that case. So here's an Incus interposition graft. So we've taken the Incus out, we've reconstructed and repositioned it so that it is now connecting the long process or the manubrium of the malleus with the superstructure of the stapes. So here we see the anterior and the posterior crura of the stapes that are in place going over to the oval window. So we've taken the Incus out of position, we've disarticulated it, and reconstructed it to connect it directly from the malleus to the stapes itself. Now, when I do a CT, I often look on the axial plane for those anterior and posterior crura of the stapes. I want to be able to see them. If I can see those structures very well, I think that the study was done well and done adequately. But sometimes if I see those structures too well, I might think that we have a component of tympanosclerosis. Maybe we have some thickening of those crura. So if I ever see a patient that has conductive hearing loss and I see thickening of these crura, I may think that that patient may have had long-term infection and may have tympanosclerosis, which is scarring down the anterior and posterior crura of those stapes. So another example of a case, here's an axial and a coronal CT, and here's another Incus interposition graft. It looks very unusual. It doesn't look like the normal. So here we have the Incus interposition graft that's in place that's trying to connect the malleus to the Incus at that location. So just another example of an Incus interposition graft. If you're not at a place where you see a lot of neuroodontology work, you may not see these cases very frequently, but just so you understand what these different plasties are. So this is an example of a plasty where we may not be putting man-made structures and replacing the ossicular chain. We're trying to use the ossicular chain itself and repositioning the Incus to form that bond between the malleus and the stapes. So next we talk about sometimes the PORP and the TORP. So the PORP is the partial ossicular replacement prostheses. So here we're replacing part of the ossicular chain in order to articulate the tympanic membrane with the stapes superstructure. So depending on the patient and how we're reconstructing it, here's an example of a PORP. So we still have the stapes footplate, and we still see the anterior and the posterior crura of the stapes, but we have connected the stapes superstructure directly with the tympanic membrane. Now, sometimes we see these cases where we have resected all of the ossicles, and sometimes we see these cases where we've left part of the ossicles in place, but we have bypassed them to directly connect the tympanic membrane to the stapes superstructure themselves. So if we still see the crura of the stapes, but we see some metal in there, then we're thinking about a PORP, a partial ossicular replacement prosthesis. So here's an example case. This is a coronal CT. I'm at the level of the duck head, so I should be near the level of the oval window itself, and I see the oval window niche that's just above the cochlear promontory. But in this case, from the tympanic annulus, the inferior attachment of the TM, as I follow the TM up, I see some thickening of the tympanic membrane, and I see a metallic structure that's going up towards the superstructure of the stapes. So if on my axial sections, I still see the anterior and posterior crura of the stapes going up to the oval window, I'm going to think that this is a PORP, a partial ossicular replacement prosthesis, PORP. So here's another example. So here's two images from an axial section. So we've had a mastoidectomy approach to the middle ear itself, and we have a metal head that's connecting the tympanic membrane, and we see a metallic portion going inferiorly, but I do still make out the anterior and posterior crura of the stapes themselves going up into the oval window. So I do still see a portion of the ossicles. So this is going to count as a PORP, P-O-R-P, a partial ossicular replacement prosthesis in this case. Here's another case. So here's a coronal CT. So I see a metallic metal artifact connecting to the tympanic membrane, and I see a straight line going over towards the oval window niche. But if I still see the anterior and posterior crura of the stapes going up to the oval window itself, I know that that's a PORP, P-O-R-P, in that case. Now, there are a lot of different make and models. Some of these have a metallic head and then kind of a bucket handle that connects to the stapes superstructure, as you can imagine, that might allow for more motion of the ossicular replacement themselves. And just in this example, this is this kind of make and model. So you can imagine this metal portion here connecting to the TM, and then there's a short stem with a bucket handle where the Stapes superstructure is fitting inside of this bucket handle at this location right here. So we still have the anterior and posterior crura of the Stapes going up to the oval window itself in this case. So here's another example. So here's a PORP, and it may be difficult to evaluate sometimes. It may often look like the metallic portion of the PORP may not be pointing directly at the oval window niche. So we want to remember that we may not be replacing all of the ossicles in these cases. It may only be a PORP, a PORP, instead of a TORP, a total ossicular replacement prosthesis in these cases. So in this case, we see the metallic stem going up towards the oval window niche. We may not be able to see the anterior and posterior crura of the Stapes very well. So here's an example of this make and model of this PORP in this case. So we have a wide portion that's connecting to the TM that can be sutured to the tympanic membrane itself, and then a stem similar to that bucket handle that's connecting to the Stapes superstructure. So next we have the total ossicular replacement prosthesis. So if we replace all of the ossicles themselves, then we have a TORP, a TORP, instead of a PORP, a PORP in that case. So in these cases, we're replacing all of the ossicles, the malleus, the incus, and the Stapes, and directly connecting the tympanic membrane to the oval window itself. So here's the graphic showing a TORP, a total ossicular replacement prosthesis. So we have a wide portion, as you can imagine, being sutured to the tympanic membrane with a longer stem that's connecting all the way to the oval window itself. So when we see this and we don't see any normal ossicles, that's going to be a TORP instead of a PORP in that place. So here's a coronal CT. So we see the mastoidectomy defect with the cranioplasty mesh more superiorly. And we can think about where the tympanic membrane, in this case, it looks like it's been reconstructed. So a maringoplasty, we've reconstructed the tympanic membrane from the scutum or shield down to the tympanic annulus. So we have thickening of the TM, and we see the metallic portion of this TORP with the stem going all the way up to the oval window itself. So if I see no normal ossicles, I'm going to think that this may be a TORP, a total ossicular replacement prosthesis, rather than a PORP, a partial ossicular replacement prosthesis. Now here's an example of a bad TORP. So here's one that's obviously been pushed out of the oval window niche. So here's my duck head. The head of the duck is a vestibule, beak is a lateral semicircular canal, neck is going down to the basal turn of the cochlea. So I see our cochlear promontory of the middle ear going up to the oval window. So I should see the oval window niche here. So I do not see normal Stapes crura at this location, and I see that our prosthesis, which was normally in place on the prior imaging, has now retracted back up into the epitympanum, the top of the middle ear cavity itself that we talked about last time. So this is a bad TORP that has fallen out kind of the oval window. So you can imagine, just like the PORP, where we have a wide portion connecting to the TM, so it has these holes to be sutured easily to the tympanic membrane, a long stem with kind of a bucket handle. Well, with a TORP, we're going to have an additional portion right here that connects that bucket handle to the oval window itself. And on this case, that was retracted or pulled out of the oval window niche. So we think about the approach. How did they get there? We think about the aplasties. What did they do to reconstruct the ossicles while we were there? And sometimes more complicated, we think about the ectomies. And just like when we talk about post-operative cervical soft tissue cases, where we have a modified radical and a radical dissection of the neck, we also have a radical mastoidectomy and a modified radical mastoidectomy. There are several different kinds of mastoidectomy that are described in the literature. If we go through the EAC itself, that's sometimes called a transcanal mastoidectomy. There's a cortical mastoidectomy where we're just resecting some lateral mastoidectomy air cells. When I was doing surgery years ago, this used to be called a simple mastoidectomy. And I had a neurooncology surgeon who used to lambaste people and say there's no such thing as a simple mastoidectomy. So he preferred that these be called a cortical mastoidectomy. Then we have a canal wall up mastoidectomy. If we leave up the back wall of the external auditory canal, the osseous wall, then that's a canal wall up mastoidectomy. If we take down the back wall of the external auditory canal, that's a canal wall down mastoidectomy. Then we have a modified radical mastoidectomy. Here we're resecting the mastoid air cells. We might be resecting a portion of the ossicles, but with a modified radical, we're going to reconstruct the tympanic membrane and the ossicles, maybe with a TORP or a PORP. And then we have a radical mastoidectomy, where we're reconstructing the mastoid air cells as well as the ossicles and the tympanic membrane, and we do not try to reconstruct. We're just putting in a big myocutaneous bulk flap in that area. So those are the different types of mastoidectomies. So now we'll go through and look at these and how we see them on imaging. So if we go through the EAC canal itself, it's very different than a mastoidectomy. If it's a transcanal adichotomy or resection of the mastoids, then we may see absence of the scutum itself and the ossicles, depending on how the approach was. They might try to reconstruct it, but we may not see a defect of the mastoid air cells more posteriorly if they just went through the EAC canal itself in those cases. Next, we have a cortical or simple mastoidectomy. If we just resect some of the lateral mastoid air cells, that's going to be a cortical mastoidectomy. So everything else will be intact. We still see our ossicles. The external auditory canal in these cases usually is not disruptive, and we haven't breached the middle ear cavity itself with a cortical mastoidectomy. So next we have a canal wall up mastoidectomy. If we approach through the mastoid air cells, but we leave up the back wall of the osseous EAC, that's going to be a canal wall up mastoidectomy for us in these cases. So here we're resecting the lateral mastoid cortex and those air cells, but the external auditory canal itself is left intact. So here's an example of that case. Here's an axial CT. So I still see the external auditory canal itself, that's intact, and I see the middle ear cavity. I can still see where the tympanic membrane is, and the external auditory canal still appears normal. I still see the back wall, the osseous wall of the external auditory canal. So this is a canal wall up mastoidectomy. We've resected the mastoid air cells, but we left up the back wall of the external auditory canal. Here's another case. So we've resected those mastoid air cells, but we have left up the back wall of the external auditory canal. Now, as you can imagine with these cases, we're not going to have as good exposure in the operating room, but we'll have much better function of the skin clearance of the external auditory canal itself. So a canal wall up mastoidectomy surgery may take longer. We don't have as good exposure, but if we leave up the back wall, then we have much better skin clearance in the external auditory canal. So we compare that with the canal wall down mastoidectomy. So here we're resecting not only the lateral mastoid air cells, but we're also resecting the posterior aspect of the external auditory canal wall. So here's a case. Here's an axial T2. CSF is bright. We've had a big surgery here resecting the mastoid air cells. We do still see the cochlea of the vestibule and the semicircular canal, lateral semicircular canal here at this level, but we've resected the mastoid air cells itself. If we cut down the back wall of the EAC, then that's going to be a canal wall down mastoidectomy. So we can compare that T2 with the T1 here before contrast, and we see the very bright fat signal intensity of this fat packing in the surgical bed. And when we do a fat saturation, we see how that suppresses out with the fluid that's in our surgical cavity. So again, we remember the nose in the head and neck world. Here the nose is dark, so that's pre-contrasted. Here the nose is bright, so this is a post-contrasted image. So if the nose is dark, that's before contrast, a pre-contrasted MR. And the nose itself, the nasal mucosa and the turbinates, take up contrast very quickly. So the nose, if it's bright, that's a post-contrasted image. So we see with fat saturation how we've suppressed out that fat that's in the fat packing of this mastoidectomy bed. And we find the external auditory canal and see if that has been resected or not. So here's a case. Here's a patient who had a preauricular lesion. There's a small mass here lateral to the condylar head, and it is in front of the external auditory canal. Now, if this lesion extends back towards the cartilaginous lateral portion of the external auditory canal, we may think that we may need to resect that portion of the EAC itself. So here's this patient preoperatively. So we see that external auditory canal, and we see that preauricular lesion, and here's that patient postoperatively. So here we've resected the mastoid air cells, we've resected the anterior and posterior wall of the external auditory canal, and we've resected the ossicles. But in this case, we did not try to reconstruct the ossicles themselves. We did not try to reconstruct the tympanic membrane. So that is a good appearance for a radical mastoidectomy in this case. We've resected the mastoid air cells, and we did not try to reconstruct any of the ossicles. We just put a big myocutaneous bulk flap down over these areas. So here's that same case in the coronal views. So we have the coronal pre-operative and post-operative imaging. So preoperatively, we see all these normal mastoid air cells extending up towards the stylomastoid foramen, and we see our ossicles in the middle ear. And post-operatively, we've resected not only all those mastoid air cells, but we've also resected the ossicles themselves, and we did not, in this case, try to reconstruct those ossicles. So that is going to be a radical mastoidectomy in this case. So that's a difference between our mastoidectomy cases themselves. The radical does not try to reconstruct any of those ossicles or the tympanic membrane. So we may do a mastoidectomy through the external auditory canal, a transcanal approach. We may do an approach where we leave up the back wall of the external auditory canal, the posterior osseous wall of the EAC. That's a canal wall up mastoidectomy. If we cut down the back wall of the external auditory canal, that's a canal wall down mastoidectomy. And as you can imagine, comparing the operative time and the operative efforts between a canal wall up and a canal wall down, with the canal wall up mastoidectomy, the surgery may take longer and we do not have as good exposure, but we have a better EAC clearing of skin through the external auditory canal. But if we do a canal wall down mastoidectomy, then we have much better exposure, better visualization of the field. The surgery may not take as long, but we do not have as good clearance of skin through the external auditory canal. So with a modified radical mastoidectomy, we're reconstructing the ossicles and or the tympanic membrane. And in this case, with a radical mastoidectomy, we just resect all of the ossicles and the TM, and we do not try to reconstruct them. So those are the different types of mastoidectomy. Now, if we do a mastoidectomy, and in these cases, we breach the otic capsule, we may see different changes with the signal intensity within the cochlea and the vestibule and the semicircular canals on MRI, and we might see a change in density on CT. This is a patient who had a T2 very bright lesion. It's centered near the suture off midline, and it is enhancing, we see on the post-contrasted imaging, a good appearance for a chondrosarcoma in this case. And we see the same thing on the coronal. Before contrast here, the lesion is dark, and after contrast, it is bright. So I know that this lesion is actually enhancing. And this patient had a very complicated kind of translabyrinthine approach to get to that petrous apex. Now, very nicely in this case, they resected the external auditory canal, they resected the ossicles as an approach kind of in front of the cochlea, a pre-labyrinthine approach to the petrous apex itself. So we see this fat packing at this location. And nicely, very eloquently, they were able to dissect and leave the bone around the facial nerve itself. So here's that tympanic segment of the facial nerve, and here's the descending mastoid segment. So they very nicely did surgery where they resected all the mastoid air cells, but they left the descending mastoid segment of the facial nerve intact, but they did a very nice approach to the petrous apex. And with a scope, you can actually cross midline with an endoscope at the skull base itself. These guys were actually way over to the other side through their unilateral approach on their endoscope. But postoperatively, we image this patient, and just like in the cervical soft tissues, postoperative temporal bone cases can be very confusing. And in this postoperative MRI, you can see the radiologist was measuring out this area. They saw this area and they saw that it was bright on the T2 sequence. So they mistakenly thought that this was recurrence of the tumor at this level. You can see how they were measuring it. And this was a combined approach. It was actually a middle cranial fossa approach and a translabyrinthine or pre-labyrinthine approach to get to the petrous apex. So the neurosurgeons and the neuroontologists were both arguing for several days because they both thought that the other one had left tumor, because we had mistakenly called residual tumor on this case because this was bright on the T2. But you can't just look at one sequence. It is true that both chordomas and chondrosarcs are bright on the T2 imaging, but when we gave contrast, we saw that this was actually not enhancing. So this actually did not look like the pre-operative imaging at all whatsoever. And this was actually just post-operative change in that area. And when you combined when you compared the preoperative T2 imaging to the postoperative T2 imaging, this actually looked very different postoperatively. So the radiologist who read this out made two mistakes here. One, they were just looking at the T2 and they were not paying attention to the post-contrasted imaging, but also they did not know that you could cross midline with the endoscope. So they mistakenly called this residual tumor when in reality it was simply post-operative edematous changes in this case. When we do have a surgery, especially a translabyrinthine approach that breaches the vestibule and the semicircular canals, we may see some labyrinthine ossificans-like changes that happen in the inner ear structures. So if we cut the vascular supply to the inner ear, if we breach the otic capsule, or strangely, if we cut the nerves that are going to the inner ear structures, we may see increased density postoperatively within the cochlea, within the vestibule, or within the semicircular canals. So we might see earlier changes on MR with loss of the T2-like, CSF-like bright signal on T2 sequences, and later on CT, we see increased deposition within those structures themselves. So here, we very nicely compare the preoperative with the postoperative. We see that years later on this translabyrinthine surgery, we had increased deposition within the cochlea itself on this postoperative temporal bone case. We might also see enhancement, which can be very confusing in these cases. And there's a very wide range from 3 months to 3 years where we might see enhancement of those inner ear structures. This patient had a translabyrinthine approach, so we left the otic capsule around the cochlea in place, but we cut out the vestibule and the semicircular canals. And this patient postoperatively had abnormal enhancement within the cochlea. This is not residual or recurrent tumor. This is simply labyrinthine ossificans that we might see postoperatively. And when we compare the T2 imaging, here nicely we see the CSF-like normal bright T2 signal on the right side, but on the left side we see lack of that bright signal, and we see abnormal enhancement on the same place. So on MRI, we lose the bright CSF-like signal and we might see enhancement, and on CT, we might see increased deposition within those structures themselves. Here's another patient who had a similar translabyrinthine approach to the temporal bone, and we see that increased density within the basal turn of the cochlea, very different than the normal side. Remember, we always have that internal comparison, so we can compare the other side to our postoperative side, and we see here that increased density. This does not imply a recurrence or residual of tumor. We can see that with labyrinthine ossificans, just increased deposition within the inner ear structures themselves. Here's another postoperative case where we see the abnormal enhancement within the cochlea itself, and we see all the fat packing from this translabyrinthine approach themselves. This similarly was called mistakenly residual or recurrent tumor, but this is simply that labyrinthine ossificans from abnormal enhancement, and that enhancement may persist for a long time after the surgery itself. So we want to be careful about calling normal postoperative changes versus a recurrent or residual disease. In this case, we had very avid enhancement within the basal turn and the apical turn of the cochlea from these postoperative changes from breaching the otic capsule, the dense bone that is around the cochlea and vestibule. Now, another thing that may be confusing with postoperative cases is the idea of an automastoidectomy or a mural cholesteatoma. In these cases, we may have a cholesteatoma that's arising from the mastoid air cells, And because those mastoid air cells are immediately behind the external auditory canal, as they enlarge, they may extend into the EAC itself. But it might look like a surgical case when we do cross-sectional imaging. Often these cases leave behind a rind of cholesteatoma, and that's the idea of a mural cholesteatoma, that there is some cholesteatomatous tissue that's left behind in these cases. Now, we talked before about a middle ear cholesteatoma. Anytime we have a homogeneous soft tissue mass with some kind of ossicular destruction, we're going to think, if it's non-gravity dependent, that over 90% of the time, that is most likely to be a cholesteatoma in those cases. In this axial CT, we see that we're at the level of the vestibule and the lateral semicircular canal. We're at the level of the labyrinthine or fallopian segment of the facial nerve. But when we're at the level of the vestibule and lateral semicircular canal, we should be near the level of the ice cream cone. We should see the ossicles. So in this case, we have a cholesteatoma that has destroyed the ossicles and the middle ear cavity itself. If we have a case like this with a cholesteatoma arising from the mastoid air cells, here we have replacement of all of those septations and aerated areas we normally see of those mastoid air cells. And we might think in this case about a marrow replacing process. Is this something like METS, myeloma, lymphoma, leukemia, plasmacytoma, EG, sarcoid, TB, any of these things that may present as a marrow replacing process? So on the CT, we might see a little bit of expansion of the mastoid air cells with loss of all those internal septations. And when we do the MR, we see that this is very bright on the T2. It's iso to brain or muscle on T1. The lesion itself does not enhance, but there is some enhancement around the outside. That's a good appearance for a cholesteatoma. We would think with most of the differentials that we think about as a marrow replacing process, METS, myeloma, lymphoma, leukemia, we would expect that most of those would have more enhancement on this study. But a cholesteatoma, the lesion itself does not enhance. We might see some enhancement around the outside, either from the periclastic reaction that we normally think about around the cholesteatoma or from blood vessels being pushed to the periphery. But on imaging, we know that doing a diffusion and looking at the ADC sequence help us make the differential of a cholesteatoma in these cases. Those cholesteatomas, just like epidermoid cysts, will have very bright diffusion and dark ADC signal intensity consistent with restricted diffusion that help us make that diagnosis. But if we have a mastoid cholesteatoma that continues to enlarge and destroys the ossicles like this case, it may extend into the external auditory canal, and suddenly the patient describes all of this skin and debris coming out the external auditory canal, and they realize that they've lost the pressure and pain that they have over their mastoid air cells. That's a good clinical history for a mural cholesteatoma, but there is some cholesteatoma that's left behind that needs to be resected, otherwise that lesion will recur. So it can be very difficult in these post-operative cases to tell on CT when we're just looking at density, is this a mural cholesteatoma rind that's left behind, or is this, for example, a radical mastoidectomy with fat packing now that has regressed and filled in with air? These cases can be very difficult to evaluate. That's why, just like every time we're reading head and neck cases at any other location, we want to try to get as much clinical information as we can from our referring physicians in those cases. Another thing we might see, depending on your patient population, if you have neuroodontologists who are doing cochlear implants, we might see these unusual linear densities extending from the middle ear and the mastoidectomy surgical cavity into the cochlea itself. So these are small devices that have these little beads, and each of these beads can be turned on or off to try to help the patient with their hearing post-operatively. So in this example case, we can think about this as a mastoidectomy approach. This is that kind of mastoidectomy approach where we've left up the back wall of the external auditory canal. So this is a canal wall up mastoidectomy with a cochlear implant placement through the window into the cochlea itself. So on plain film, we see the cochlear implant itself that's lodged subcutaneously in the skin, and we might very faintly see a little thin curve of the cochlear implant itself in the cochlea itself. So one of the few areas where we do plain film to evaluate the temporal bones, and we can see the wires. They often put in some redundancy in case somebody starts to pull on one of those wires, but we can see the leads going into the cochlea itself with a nice spiral through that area. So a actual surgical case where we're placing the cochlear implant itself, it may look like a very kind of confusing field that we're going into with a bloody field. But on cross-sectional imaging, we can see the actual wire with those individual beads here in the basal turn of the cochlea and going up into the more apical turns themselves. So again, the approach here is a canal wall up mastoidectomy, and it's kind of a approach to the middle ear itself, and we can see where the round window is. So when I want to find the round window, I find the basal turn of the cochlea, and I look posteriorly and laterally and find this dot of air. I know that is the round window. So we have an approach to the round window, and we're trying to implant these cochlear implant beads through the cochlea itself, through that area. And then these individual beads can be turned on or off postoperatively to try to determine the best hearing for the patient. Here's another case. Again, this is another canal wall up mastoidectomy approach. We've left up the back wall of the EAC. We've done a mastoidectomy, and we're approaching the window itself, and we see the lead going into the window and up into the cochlea itself. Here again is another case where we see on CT, this axial CT, very high density of the lead going up. We see the ossicles are left in place on this case, but we're bypassing them with the cochlear implant itself. So here's another case where we see these individual beads from this mastoidectomy approach. There's some redundancy, so it might look like there's loops of wire within the mastoidectomy bed itself, but we want to see these beads going through the basal turn, and we like to extend them up into the apical turns of the cochlea themselves. Now, in this particular case, the patient came back years later, and the cochlear implant was no longer working. So this is a case where we actually have retraction of those leads. So where previously on the old study postoperatively, we saw the leads within the basal turn of the cochlea, now they've been retracted. This patient was actually playing with the cochlear implant subcutaneous leads and their skin, and after a while they were twirling it, sometimes called the twiddler syndrome that may happen with a cardiac pacemaker wires, where the cardiac pacemaker may be twirled in the chest and the pacemaker leads will be retracted. This case similarly had retraction of those leads, which are now looping into the middle ear, and they were pulled out of the round window a few years after this study was done, where we saw the leads nicely and the basal turn previously. So that is a review of postoperative temporal bone studies. This is a very complicated area, just like how we talk about postoperative neck studies. We have the radical and the modified radical neck dissection. And the temporal bone, we similarly have a radical and a modified radical mastoidectomy approach. So when I see a postoperative temporal bone case, I try to think about these three things when I'm evaluating those images. I think about the approach. How did they approach the area that they were getting to? Whether it was the mastoid air cells, or the petrous apex, the interlaudatory canal, or the CP angle. I think about the plasty. If they did breach the middle ear, did they try to reconstruct the ossicles while they were there? And I think about those different types of ectomies. Is this a canal wall up mastoidectomy where they left up the back wall of the EAC? Is it a canal wall down where they took down the back wall of the EAC? Is it a modified radical mastoidectomy where they resected the mastoid air cells but they reconstructed the ossicles and the tympanic membrane? Or is it a radical mastoidectomy where they resected everything and may have just put a big myocutaneous bulk flap filling the area, and with a radical mastoidectomy, they did not make any attempt to reconstruct the ossicles or the tympanic membrane itself. So that is a approach I try to use to try to think about logically postoperative temporal bone cases to help me evaluate them and get through those evaluations. And I thank you very much for your attention. So I'll look at the chat room if anyone has any questions about anything.
Thank you very much. that was the most excellent lecture. Thank you very much, Dr. Wiggins. I found that most enlightening, especially in view of all the different problems that we generally face with these post-operative temporal bones. And I found your inputs on the experiments that you had with the Stapes prosthesis very enlightening, because that often is a problem as to decide whether they're too deeply inserted or not.
Exactly. That was very confusing for me.
And another thing that is also very confusing is that post-operative middle ear post-cholesteatoma rechecks, and to distinguish between the subcutaneous or the fat flap and whether there's recurrence or not. And this was really very enlightening. Thank you very much.
Thank you.
Are there any questions that we are aware of?
Now you know everything I know about the post-operative temporal bone.
I'd add that.
But these are the kind of cases that, 25 years ago were very popular to be taken off the stack and put down at the bottom of the stack. People would take out complicated temporal bone and soft tissue neck studies and hang them up on the viewfinder and then immediately pull them down and put them back at the bottom of the stack and hope somebody else would get to them later.
Nowadays, they get left on the work list. Nobody picks them until the end of the day.
Now we just leave it on the list.
Thank you very much. I wonder if I can ask the organizers just to check if there's any questions from our audience before we close the session.
I don't see it here.
Okay.
I guess everyone is dumbfounded.
Yes, they must be, because that was really great. And then just leaves me to say thank you very, very much for your time and this wonderful lecture. And thank you everybody for attending. And yes, have a very good evening all.
Thank you. There was one question about DWI. Does DWI have any role to distinguish residual tumor recurrence from post-inflammatory changes or fibrosis in the 3 years post-op? I think DWI has a huge role if the patient is a cholesteatoma. When we're trying to differentiate a small cholesteatoma or residual cholesteatoma, whether you're doing a version of an EPI or non-EPI diffusion, working with propeller, depending on your vendor, or if you're doing axial or coronal, I find the axial is a lot easier for the blooming that happens around the air cells themselves. But specifically with cholesteatoma post-operative cases, sometimes if somebody has an abscess, then we do see restricted diffusion, but that's sometimes a little bit different than a cholesteatoma case where we're thinking about the restricted diffusion of a cholesteatoma more like an epidermoid cyst. So I would say that in the post-operative cases of a cholesteatoma, we do often use diffusion imaging to try to differentiate those cases, and that's where it's very helpful. For the other pathologies, if it's not something that shows restricted diffusion preoperatively, just like all the brain tumors, complicated cases that we have, we need to go back and look at the preoperative or pre-therapy treatment changes to see how the pathology looked on cross-sectional imaging beforehand when we compare our post-operative imaging to that. Just like the complicated chondrosarcoma case I showed, you can't just look at the post-operative, you have to compare it side by side with the preoperative to really understand what's going on to this complicated anatomy that's around the temporal bone. So I would say, yes, there is definitely a role for cholesteatoma cases and try to differentiate that from inflammatory or infectious changes. The ADC values, as we see with malignant tumors, things that are hypercellular are more likely to be malignant, therefore they have low ADC values in those cases. That's something that we've looked at in several different body parts to try to help differentiate benign from malignant in that world. So yes, I use ADC more and more in the extracranial head and neck and the temporal bone, and I'm actually using it more than DCE and some of the other kind of fancier, more advanced imaging techniques. So I've been using ADC more and more in the extracranial head and neck.
Yes, excellent. Thank you very much. Yes, that it is a useful, very useful sequence for those complicated cases. But as you said, you need to look at it before pre-operative and compare those two. Any other questions?
Okay, well, thank you very much for your attention.
Thank you very much, Dr. Wiggins, and have a very good evening.
You too, thank you.
Thank you. Okay, thank you, everybody. Have a nice evening. Goodbye.